Thalassemias are hereditary blood disorders characterized by mutations affecting the synthesis of hemoglobin chains, leading to microcytic hypochromic anemia. They are classified based on the affected globin chain, alpha or beta, and the severity determined by the number of mutated alleles. Alpha thalassemia. Genetics. 4 genes control alpha globin production. Mutations can lead to 1 or more gene deletions. Forms. Silent carrier. 1 gene affected, typically asymptomatic. Alpha thalassemia trait minor. 2 genes affected, mild or no anemia. Hemoglobin H disease, intermedia, 3 genes affected, chronic hemolytic anemia, possibly requiring transfusions. Hemoglobin Bart's, major, all 4 genes affected, results in hydrops fetalis, often fatal. Beta thalassemia. Genetics. 2 genes control beta globin production. Mutations lead to reduced BEPA plus or absent beta synthesis. Forms. Beta thalassemia minor, 1 gene affected, mild or no anemia. Beta thalassemia intermedia, 2 genes affected, variable anemia, may need occasional transfusions. Beta thalassemia major, Cooley's anemia, 2 genes severely affected, BEAT0, requires regular transfusions. Clinical features. Beta thalassemia major, severe anemia, growth retardation, skeletal deformities due to marrow expansion, hepatosplenomegaly, and risk of iron overload. Alpha thalassemia major, hemoglobin Bart's, hydrops fetalis, often incompatible with life. Diagnostic, CBC, microcytic hypochromic anemia, peripheral blood smear, target cells, teardrop cells. Hemoglobin electrophoresis, HPLC, identifies hemoglobin variants, elevated HbA2 in beta thalassemia minor, HbH in hemoglobin H disease. Genetic testing confirms specific mutations. Treatment, beta thalassemia major, regular blood transfusions, iron chelation therapy to prevent iron overload, potential stem cell transplantation. Thalassemia major, management is generally supportive, as most affected fetuses do not survive to birth. Complications, iron overload, due to repeated transfusions leading to organ damage, bone deformities, resulting from bone marrow expansion. Thalassemias are more common in regions where malaria is endemic, with alpha thalassemias frequently seen in Asian and African populations, and beta thalassemias in Mediterranean descent. The prognosis varies widely depending on the type and severity of thalassemia, with minor forms often requiring no treatment, while major forms necessitate ongoing medical intervention. Clinical case, beta thalassemia major. Patient information. Age, 4-year-old male, ethnic background, Mediterranean descent. Medical history, diagnosed with beta thalassemia major at 6 months of age following investigation for failure to thrive in pallor. Presenting complaint, the patient presents for a routine follow-up at the pediatric hematology clinic. The parents express concerns about his slow growth and frequent fatigue. History of present illness. The child has been receiving regular blood transfusions every 3 to 4 weeks since diagnosis to manage severe anemia. Despite transfusions, the child often appears pale and is less active compared to peers. The parents also note that he has developed a prominent forehead and cheekbones. Physical examination. General. The child appears small for his age, with noticeable pallor even post-transfusion. Vital signs. Within normal limits for age. Abdominal exam, mild hepatosplenomegaly. Skeletal exam, prominent facial bones, particularly the forehead and maxilla, chipmunk facies. Hashis diagnostic workup, CBC, persistent microcytic hypochromic anemia despite recent transfusion. Iron studies, elevated serum ferritin indicating iron overload. Hemoglobin electrophoresis, confirms the presence of fetal hemoglobin HbF and absence of HbA consistent with beta thalassemia major. X-ray skull X-ray shows hair-on-end appearance due to marrow expansion. Management plan. 1. Transfusion therapy. Continue regular blood transfusions to maintain hemoglobin above 9 to 10 Greller. 2. Iron chelation therapy. Intensify iron chelation to manage transfusional iron overload, monitoring liver and cardiac function closely. 3. Bone health. Supplement with calcium and vitamin D to support bone health. Consider endocrinology referral for growth monitoring. 4. Splenectomy. Consideration for splenectomy if hypersplenism contributes significantly to anemia or if transfusion requirements increase. 5. Stem cell transplant. Evaluate eligibility for hematopoietic stem cell transplantation, which offers the potential for cure. 6. Supportive care. Ensure comprehensive care, including psychological support for the child and family, nutritional support, and regular monitoring for complications of thalassemia and its treatment. Outcome. The patient's transfusion and chelation therapy regimen is adjusted based on current guidelines, with close monitoring for signs of iron overload. Discussions regarding the potential for stem cell transplantation are initiated, with referrals made to a transplant center for further evaluation. Discussion points. The importance of a multidisciplinary approach in managing beta thalassemia major, addressing both the hematologic condition and its systemic complications. The challenges of managing transfusional iron overload, emphasizing the need for effective chelation therapy. The potential for curative treatment with hematopoietic stem cell transplantation and the associated risks and considerations.